Welcome to this Step 3 review on pain and symptom management. This video is brought to you by Roadmap to Residency. Our goal today is not to reteach palliative care from the ground up. It is to show you how these question stems are built and how to attack them so that the next best step becomes automatic. Make sure you are also working through your question bank and a solid review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, how to assess pain the way the exam wants, and how to climb the analgesic ladder one rung at a time. Second, how to start and titrate opioids safely, and why you pair every opioid with a bowel regimen. Third, how to manage nausea, constipation, and breathlessness at the end of life. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to read every pain vignette for what is really being asked. Start with the last line of the question. That sentence tells you whether the STEM wants the best initial medication, the next step after a starting dose has failed, or the drug to add for a side effect. Once you know the question, go back and read the STEM with that goal in mind, and you will stop drowning in detail. Then anchor on the goal of care. When the STEM describes advanced disease and a focus on comfort, aggressive workup is usually the wrong answer, and the right answer treats the symptom in front of you. On this exam, the goal of care is a clue, not background noise. Strategy 2 is the analgesic ladder mindset, and it drives most pain questions on this exam. First, match the drug to the pain. Mild pain starts with a non-opioid, such as acetaminophen, or an anti-inflammatory. Moderate to severe pain, and most cancer pain, moves up to an opioid. Be suspicious of any answer that jumps straight to a strong opioid for mild pain, or that offers only a non-opioid for severe cancer pain. Second, anticipate the side effects. Every opioid answer has a shadow side effect, and the right choice often prevents it. Start a bowel regimen the moment you start an opioid. Expect early nausea that fades on its own, and never leave constipation untreated. When two answers both relieve pain, the stronger one also plans for the predictable side effect. Now, let us focus on opioid initiation and titration, because the exam tests this in a very predictable way. First, start low with a short-acting opioid. For a patient who has never taken opioids, begin with a low as-needed dose of an immediate-release opioid, so you can learn how much drug the patient actually needs before committing to a long-acting form. Second, titrate up, then convert. Add up the total short-acting opioid used over a day, convert that daily requirement into a scheduled long-acting opioid, and keep a short-acting dose available for breakthrough pain. Rising pain calls for a higher dose, not a switch to a weaker drug. Third, respect renal function. In poor kidney function, the exam avoids meperidine and morphine because of toxic buildup, and favors safer agents such as hydromorphone or fentanyl. A STEM that mentions kidney disease is steering you toward the safer opioid. Let us work through our first practice question. A 60-year-old man with widespread cancer reports constant deep pain rated 8 out of 10 despite scheduled acetaminophen. He has never taken opioids and his kidney function is normal. He is alert and comfortable at rest, but in pain with movement. The question asks for the most appropriate next step. Notice that a non-opioid has already failed, and that this is severe cancer pain in an opioid-naïve patient. Read the 4 options carefully, and pick your answer, then we will walk through the reasoning together on the next slide. Let us break this down. First, spot the pattern. This is severe cancer pain that a non-opioid has failed to control, in a patient who has never taken opioids with normal kidney function. That is the classic setup for starting an opioid. Second, apply the rule. For a patient new to opioids, you start low with a short-acting opioid given as needed, then titrate to effect. So the answer is to start a low-dose, short-acting oral opioid as needed. Third, eliminate the wrong answers. Continuing only acetaminophen leaves severe pain untreated. Starting a high-dose, long-acting opioid in an opioid-naïve patient risks dangerous oversedation. Meperidine is avoided because of toxic buildup. The correct answer is the low-dose, short-acting opioid. Here is our second practice question, and this one tests a side effect. A 70-year-old woman with cancer has good pain control on a scheduled long-acting opioid. Over the past week, she has had hard, infrequent stools and mild abdominal discomfort. Her abdomen is soft, with normal bowel sounds and no sign of obstruction. The question asks for the most appropriate next step. The key detail is that her pain is well controlled, and the new problem is her bowels. Pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, recognize the side effect. Good pain control on an opioid, plus hard infrequent stools and a benign abdomen, is opioid-induced constipation. This is the one opioid side effect that does not fade with time, so it must be treated rather than waited out. Now, why does the stimulant laxative win? A stimulant laxative regimen directly treats the slowed gut, which is why it is the answer. Stopping the opioid needlessly sacrifices good pain control. Fiber alone can actually worsen things when gut movement is slowed and does not fix the cause. Imaging chases a mass that the benign exam does not support. The correct answer is to start a stimulant laxative regimen. Let us talk about nausea and constipation, because the exam handles them in a very specific way. First, prevent constipation from day one. Tolerance to constipation never develops, so the exam expects a stimulant laxative regimen started alongside every scheduled opioid, and fiber alone is not enough when the gut is slowed. If a STEM starts an opioid and offers a bowel regimen as an option, that is usually the point being tested. Second, match the antiemetic to the cause. Early opioid nausea is usually mild and settles within a few days. When a STEM points to a specific cause of nausea, choose the antiemetic that targets that mechanism, and remember that constipation itself can present as nausea, so relieving the bowels can relieve the stomach. Here is our third practice question, on breathlessness at the end of life. An 80-year-old man with advanced cancer and a comfort-focused plan has distressing breathlessness at rest. His oxygen level is adequate on room air, and no further disease-directed treatment is planned. He and his family want him to be comfortable. The question asks for the most appropriate next step. Notice the comfort-focused goal and the fact that his oxygen level is already adequate. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, treat the symptom. This is a comfort-focused patient with distressing breathlessness at the very end of life, and the exam wants that symptom treated directly. A low-dose opioid is the first-line treatment that reliably eases the sensation of breathlessness, which is why it is the answer. Now, the key distinction between the wrong choices. Intubation flatly contradicts the stated comfort-focused plan and is the overkill trap. Urgent imaging and a lung scan chase a diagnosis that would not change the comfort plan. Waiting for the oxygen level to drop ignores real suffering, because you treat the distress, not the number. The correct answer is the low-dose opioid. Here is a pearl that ties these vignettes together, the comfort versus cure filter. First, name the goal of care before you pick an answer. When the patient has advanced disease and a comfort-focused plan, the goal is symptom relief, and any choice aimed at reversing the disease is usually wrong, no matter how thorough it sounds. Then, cross off the overkill answer first. Intubation, urgent scans, and invasive procedures are the planted traps in these questions. What remains is almost always the answer that treats the symptom in front of you, whether that is an opioid, a laxative, or an antiemetic. Naming the goal and cutting the overkill will carry you through most of these stems. That wraps up our review of pain and symptom management for Step 3. Remember the core ideas. Read every pain stem for what is really being asked, and climb the analgesic ladder in order. Start opioids low and short-acting, titrate to effect, and pair every opioid with a bowel regimen. Treat nausea by its cause, and treat breathlessness at the end of life with a low-dose opioid. And always name the goal of care, then cross off the overkill answer. The best way to lock this in is to drill questions in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.